I don't think we all know each other. So I'll start first. My name is Bukola. I'm currently in the UK, but I'm from Nigeria. And I've been doing sickle cell advocacy for a long time now, about 15, 16 years now. Mostly patient advocacy, but in the last kind of 7 years, I focused a lot on blood donation. I run an organization called Haima Health Initiative, which is based in Nigeria, where we try to get as many young people as possible to register as blood donors. We also do a lot of work campaigning um, to get people on our donor register, which is the largest online voluntary blood donor register in Nigeria. And we primarily target young people, so usually at universities, camps, things like churches, mosques, stadiums, anywhere where there's a large crowd of young people is usually where we target. And our goal is to just make sure as many young people are signed up as blood donors and are giving blood as possible. I also do a lot of work with the Sickle Cell Aid Foundation, where we do advocacy on sickle cell, patient advocacy, trying to get people to understand the patient experience, as well as working with doctors and nurses to also raise awareness about different aspects of sickle cell. So I'll pass on to Jen to do a similar introduction before we kind of get into today's topic.
Okay. Hi, everyone. I was going to say good morning, good afternoon. I'm Janika Leah. I'm from Birmingham in the UK, but I'm currently in the Caribbean, in Jamaica, doing some work over here. So I am a patient first and foremost, but I'm also a children's author. I have a children's book series, which is called My Friend Jen, which aims to educate and give confidence to young people growing up with sickle cell. I also have an organization with the same name, My Friend Jen, where we focus on creating educational resources to give people awareness and education around sickle cell, blood donation, and everything that can help to improve the lives of those impacted by sickle cell. So we have a organization in the UK, which is My Friend Jen, and we're also in the process of setting one up in the Caribbean, so that we can implement the same things that we do in the UK across the Caribbean as well. And I am previously the president or the former president for the European Sickle Cell Federation. So I also have quite a good, I guess, scope of kind of like sickle cell across the globe in terms of like the UK, Europe, and also the Caribbean. So I'm bringing that perspective and insight to you all today.
Thanks, Jen. Because Ivy, I don't know if you've met Jen before. I think it would also be helpful to have some brief introductions from your side as well.
Wonderful, Janika. Thank you so much. And Nicola, thank you so much for joining us today. So today, of course, is supposed to be our inaugural session of our peer learning exchange. This exchange comes from the Sickle Cell Disease Coalition, of which I'm the manager. So hello, welcome. The Sickle Cell Disease Coalition is over 100 organizations with national, international interest in sickle cell who come together and be able to help each other come together and harmonize and align on sickle cell projects and collaborations and initiatives to be able to unify and share decision making across the board. And so we as a coalition, we work together to be able to help coordinate these conversations, be able to bring priority topics, and of course, build this network to be able to share about community events, what is everybody doing in sickle cell, and how can we support each other and be better partners across a collaborative space. And so this initiative was built on the idea that we have a lot of wonderful experts in the field that are doing great work, and we wanted to be able to leverage that and be able to spotlight that through these various sessions and be able to share that across the greater community. So we've invited members, but as well as general community to the learning exchange just to see and be able to share what lessons we've learned and what are some great practices that we can all encourage each other to utilize. We have several of our team on the call today, as well as one of our co-chairs from the who helped develop the initiative. But we are recording the session, so those who may not be able to join us. So hopefully you'll be able to cover your information, and we'll still get that out there to be able to share with the greater community.
Thank you, Ivy. So I think we'll kind of delve into it now. I'm going to share my screen. Let me know when you can see it properly, please.
Yes, now we can see it.
Okay, great. So yeah, I remember when Ivy reached out for to start this peer learning session. This topic really jumped out at me because it's something that I think I've been thinking a lot about how we can best make that collaboration happen, right? Oftentimes we do a lot of work with individual sickle cell advocates, but I think doing work with patient communities is something that hasn't really been thought about and something that hasn't really been fully utilized in a way that it can, because I really think it has a lot of potential. And when I thought about this topic as well, I thought the best person to ask to work with me on this is Jenica, because Jenica has a lot of experience working with sickle cell communities, as well as working individually in different spaces, like she had mentioned. So for me, this was really important, especially for the end goal of improving research and healthcare delivery, which is ultimately what we're all working at. So I will start by giving like a general overview of what is the actual problem that we are talking about. So we all know that sickle cell disproportionately affects marginalized communities, and it's the same thing in Nigeria. A lot of the challenges that come with sickle cell affect people, especially when they are from low economic backgrounds, or they have challenges with literacy and things like that. And so it kind of, with sickle cell disease, I feel like oftentimes it's like a double whammy. So you're dealing with the challenges of the condition itself, but you're dealing with all the socioeconomic challenges, you're dealing with all the challenges that come overall. So it's that balancing act that I think makes it really tricky. Then the second challenge is we've seen a lot of clinical trials in the last kind of 10 years, more than I think has ever existed for sickle cell. But we still see a serious underrepresentation in research, and also the ability of the research to actually be communicated to those communities that need it the most. Oftentimes they're like pretty far away, and trying to get that translated to them. So I remember doing some talks in Nigeria, and a lot of the sickle cell patient community never heard of voxelotor, never heard of any of these new therapies that had come out. And so it was now clear that there was also a communication gap, right? Like in the sense that even when we do clinical trials, or where there are new drugs or new therapies out there, there isn't an opportunity to get it to that information to those patients. So we did a survey to actually find out about the new therapies, to find out, have you even heard of any of these things? We found that a lot of people have heard of stem cell, bone marrow transplants, but a lot of the new therapies that have come out in the last 5-10 years, that it's just not getting through. And then finally, the challenge of the delivery. So we know how fragmented the healthcare tends to be for sickle cell, and the limited access. I can speak from the perspective of Nigeria and the UK, and I'm sure Jen can bring that perspective of the Caribbean as well as the UK. Oftentimes, you have, like in the UK, as a good example, you see your general practitioner who's for your regular things. So things like you have a flu, you have a cold, and things like that. Then you see a specialist who's your hematologist for all your sickle cell related needs. But oftentimes they're not communicating with each other. And so it often feels like you're explaining yourself over and over and over again. And sometimes you talk to your GPR about a certain thing, and they say, oh, once they hear you have sickle cell, they're like, oh, I can't talk to you about it, or it has to do with your sickle cell. And you're like, oh, not everything has to do with my sickle cell. I might just have this problem. And it's the same thing when you go to your hematologist. They'll say, oh, this isn't a sickle cell related problem. You can talk to a general practitioner. So you constantly have that back and forth with the healthcare in terms of the delivery and the support that you're getting. It's usually very fragmented. And we think that patient support groups are an opportunity to bridge that gap in terms of the delivery of the healthcare, in terms of the communication. So this is where I will come to the main topic of today, which is the power of patient communities. So when I talk about patient communities, what am I talking about? We're talking about different types of groups that exist where patients are speaking to themselves. Oftentimes, they are active patients. They can be parents of children who have sickle cell. They can be just supporters, like husbands of or wives of people that have sickle cell. And sometimes they can even be carriers. So people who are AS, for example, are taking part in these communities, and they're active usually on social media. So there are Facebook groups, WhatsApp groups, Instagram groups, and then there are in-person communities. So there's like a couple that I'm part of in the UK, for example, that are mostly just patients, and every day they're just discussing different things. So it's like, hey, has anyone ever noticed that you have this thing with your eye when you have sickle cell? What's the experience? How have you managed this? How have you treated this? Because a lot of times sickle cell can be very isolating, right? And I think that there is a tendency now for everybody, once you have a symptom, you go to ChatGPT and then you put in the thing, or you go to Google and you put in the thing. But there isn't really like a substitute for speaking to other patients who have sickle cell and hearing their experience and saying, hey, is this something that's common? Am I alone here? Should I go see a doctor? Is there anything that I can do as a home remedy? That's one. Two, there's a lot of work that sickle cell patient communities do around advocacy around emergency care. So we have a lot of times where a patient is in hospital, they're like, listen, I've been in hospital for 12 hours, I haven't been seen, I'm going through this challenge. What can I do? Who can I seek help with? And then you have people in the patient community groups that are able to support. Sometimes they're able to actually come to the hospital, they're able to reach out to doctors, they're able to use social media to call out certain things that are going on. And so they're actually really powerful groups and really powerful ways for patients to get support. A lot of times we see, especially with guys, for example, and they have this resistance of going to the hospital for various reasons. And they come to these groups and they ask the questions like, hey, I've been in pain for a couple of weeks. I don't want to go to the hospital because of, whatever reason. Is there something I could do? Is there a remedy I can take? And so on. Sometimes people are about to undergo a major surgery. They come in and say, has anyone had a hip replacement? How long was the recovery? What was the physio like? So it's really an information sharing and support network that has these groups of people, and they really offer lived experience data. So they're offering insights into the daily challenges and the things that are really concerning for sickle cell patients. I think sometimes with research, there can be a lot of focus on certain things like cures, but if you speak to a lot of people who have sickle cell, they'll say a cure is really great. I just don't know that is for me. Right now, what I really need is this, and this. And that's where the data comes from patients' communities. They can actually tell you what the patients are looking for, the actual solutions that they're looking for, the things that are most pressing to them, and the tools that they would like available. So we see these patient communities as that trusted bridge between the patient communities and their support network and loved one, and researchers, clinicians. So it offers a lot of, we think, insights and data for researchers and healthcare providers. And sometimes these patient communities can actually be championed by healthcare workers. So I gave the example of Maya Bloomberg on Instagram. She has a really huge following, I think over 14,000 followers, and most of them are people living with sickle cell, because she does a lot of community advocacy on sickle cell, putting out messaging around, hey, if you have this is what your blood work means. These are what your key stats are. These are the things you should be looking at. These are the key exams or tests you need to be taking every week. So people like that as well create communities on social media using their platform or using their advocacy, and they're also really valuable tools to connect and to bridge that patient healthcare provider gap. So we see patient community groups as a source of truth for a lot of patients and for a lot of families, and they're really able to share things that are vulnerable, things that sometimes they feel like they can't share with their healthcare providers. And so we divided this talk into really kind of two sections. So I'm going to talk a little bit about the benefits of these communities to healthcare delivery, and then Jen will go into her experience with patient communities and talk about the benefits for researchers as well. So in terms of the benefits for healthcare delivery, I've already spoken and touched on a little bit about it. It's really understanding the patient need, right? Understanding what is it of the most concern to patients. And yes, the healthcare delivery is obviously the key part of it in terms of what we're talking about, but then also all the social aspects of living with sickle cell are really discussed in these groups, and they're really an opportunity to know. So what are the employment challenges that a lot of adults with sickle cell are facing? What are the school challenges that they're facing? What are the kind of stuff they're seeing on social media? Jen put out a really interesting post yesterday about some of the comments that people make when you complain about a healthcare system, right? And so some of the like pushback that you're getting from healthcare workers in terms of the complaints that sickle cell patients are having. A lot of things, something else that's really discussed, I think is not as much of an issue in UK or in the West as it is in Nigeria, is stigma. So there's, I'm part of a patient support group in Nigeria, and there's a lot of stigma. You know, people are often like, when do I tell somebody I'm dating that I have sickle cell? When do I, mention to my employer that I have sickle cell? I don't want to declare, this particular thing in case it jeopardizes my job. I don't want to tell, my friends in case this happens. And so all those issues around stigma are really there. We've seen parents when they come and they say, I haven't told my child they have sickle cell. They're 10, they're 11. They're asking me all these questions. How do I approach it? And so these groups provide those avenues and those bouncing boards around the social aspects of sickle cell as well. So the stigma, the discrimination, the challenges with employment, and so on. And then they also talk about accessible health services as well, right? People oftentimes share contacts of nurses and say, go to this place and ask for this nurse. She's really good. She's, she's better than this person, and so on. And so they act as referral centers as well. And the other thing is the shared decision making. That shared decision making builds trust and it builds adherence as well. We often have people in the group that are saying, oh, I don't like taking my medication, or I don't like going for my bloods, or I don't like, doing this particular thing. And these groups have opportunities for others to encourage themselves and say, hey, no, I think it's really important for you to take this medication if you've been prescribed for it. I think it's really important you get your eyes checked every year, and so on, and passing on some of that information that sometimes doesn't land as well from the healthcare provider, right? Because sometimes if the healthcare provider is providing a whole bunch of information, it can just seem really abstract, comes out of a textbook. Okay, just do your bloods every year, do your kidneys, check your this, check your that. There isn't really that time for that personalized understanding of why it is important for you to do these things. And these patient support groups provide that support, right? And that additional education that is often needed or often missing for a lot of patients, both adults and in children. The next point I want to speak about is the confidence that it builds. So these groups really build confidence for a lot of people with sickle cell, because you're often really unaware or really overwhelmed by the information that you're getting. And it's an opportunity for warriors to teach other warriors about the condition, about the lived experience, about the things that they should be going to go and ask, right? A lot of times, and especially this is in Nigeria, there is an intimidation when you are speaking to your doctor, right? You don't see them as an equal, or you don't see them as a peer. It's someone that's up here and then you're down here as the patient. And you really need to learn to have that confidence to ask the questions, sometimes to push back as well and say, no, I don't like this particular medication, or I don't like this particular thing. It's giving me these side effects. I don't think it's working for me. A lot of patients don't have that, right? So instead of pushing back on something, they'll just say, okay, and they'll take the medication home and they'll just not use it. And so it's actually helping warriors have that confidence to have a conversation with their healthcare provider to say, this is not working for me. Can we try something else? Can we do this? I'd rather not do this, and so on. I think those things are so important in healthcare delivery. I remember the first time I started building this was I had a doctor when I first moved to the UK. I think I was around 19, and he said something which remained with me for till now. He said, "Oh, I'm not the expert on sickle cell. You are. I just studied it, but I'll never have sickle cell. You are the expert on sickle cell, so you have to tell me what works for you." This was in regard to like medication and painkillers especially. And for me, that really shifted my perspective because I thought, oh, he knows more about sickle cell than I do because I mean he's a doctor, he studied it. But he really shaped that perspective to say, no, actually, you're the patient, you're the one with the lived experience, so you are the expert in sickle cell. And so I need you to kind of walk with me on this journey. He was definitely one of the best doctors I've ever had in my life. And that for us is like really good example of what good looks like and how it can help empower the patient to be able to come to like meetings or those healthcare visits with confidence, with honesty as well, right? To be able to actually say, this is what's going on with me. So I think that that's very important, and that's where some of these healthcare, so these patient support groups work well, right? Because it allows warriors to build the confidence of other warriors, which ultimately improves their healthcare if they're able to do these things. And so for us, we see this kind of patient support groups as really that kind of bridge between what patients are feeling, what they're saying, what they're struggling with, and healthcare providers in terms of how they can really take healthcare delivery to the next level. So I'll pass on to Jen to go to the next section of the presentation.
Thank you. That was really good and really insightful. And I feel like we're going to have a lot of overlap in terms of what we're discussing. So what good looks like, and as Bookie said, I'm kind of looking at like the research. So engaging the community for research from inception, which means we want to be able to give patients the value that they deserve. As Bookie said, we are actually the experts. So it's about co-creating and not consulting. I'm going to apologize in advance because I am recovering from a cold, so excuse me coughing. So I would say like a true partnership means valuing the lived experience of a patient alongside the clinical expertise. And there's one thing that I think is apparent within the sickle cell space, which is patients only make up a small portion of the research and what happens in the long run. And actually, in my opinion, I believe that we should be par on par with the clinicians because, as it's already been said, we can explain things that perhaps clinicians, researchers, and doctors wouldn't necessarily understand or wouldn't necessarily think about. So in terms of this, I would say that we need to be able to value expert patients. There are a lot of them in the community, as well as those that are just, perhaps they're not confident in speaking about sickle cell to like on an expert level, but they still have a knowledge and experience that should be considered when it comes to making these decisions. And along with that, patients should be involved at the very beginning of the study design and not just an afterthought. So there are too many times where a treatment has already been developed, the ideas already come about, it's already been developed. And then at the last minute, when everything has already been decided and you've already know the rollout process, the patients are then the afterthought in terms of, oh, let's engage with some patients to consult with us and see what they think on the literature. Let's see what they think about the write-up. Let's see if the explanation makes sense. And then we have to do all these proofreading and there's a lot of back and forth, and there will be things that as patients we perhaps don't agree with, or the way that we interpret things will be different to the way that it's explained. So from a research point of view, it's really important to involve patients from the beginning so that you can end up building something that is going to be valuable and also not really time wasting. We've seen it in a lot of the new treatments that have come out recently, that what one side thinks in terms of a clinician and research perspective is not necessarily what the patients may be expecting. On that same topic, building trust through transparency, I think it's important that when engaging patients as well, we do highlight and acknowledge that there is a historical mistrust in terms of research within certain communities and definitely within the sickle cell community. These are things that we should actually pay attention to and not try and brush over, because if we acknowledge what these things are, and then we can build trust around, this is something that has taken place, but this is how we're going to overcome it through this process to make sure that this doesn't happen. And there's transparency in terms of how the research is going to be done, what's going to happen to the research once it's taken, what happens to trial data, what happens to patient data, and all of those things. It really gives patients more confidence and more belief in what is taking place and what the outcome would be. The mistrust that has happened in various different communities, I feel like it does stem from a lack of communication and a lack of openness as well. So instead of shying away from these things and acting like they haven't happened, I think it's important to acknowledge them and to share what will be different through this process so that patients can have that trust. And as part of that as well, sharing clear information about the aims, the risks, and the benefits in a language that patients understand. A lot of the time when new treatments are coming out or there's trials coming out, we hear about how amazing it's going to be, the benefits, how it's going to help. We very rarely hear about the risks that may be involved, the symptoms and side effects that may be involved, the trials that haven't gone well and what happened as a result of that, like why did they fail? We always hear about the positive. And the negative thing that happens with that is not just within the patient community, but also with the external community, in terms of our support systems and stuff. People hear the news of new treatments and new drugs and they think, oh my gosh, this is amazing. But we don't actually hear the truth. A lot of the time when these drugs are pulled from the market, there's a whole media outburst in terms of when the drug is brought to market, but when they're pulled from the market, no one even knows. So our wider community believes that there are a lot of treatments and research and drugs available for sickle cell, when really 3 of the new ones that came to the UK were all pulled from the market, like within a year of each other. So it is important that we highlight the risks, the benefits, the access, and all of these things in an accessible language. And another thing I'm just going to add to that as well is I think it's important to explain the process that takes place in terms of research, because a lot of patients as well, unless you are within the space of working with the company and understanding what happens, patients don't have a vast experience on what a trial means. What is phase 1? What is phase 2? What happens when a trial is brought to market through like an orphan drug agreement where it's pushed quickly, but then what does that then mean if there are things that go wrong? It's important to explain these processes so that should anything happen, we don't have the mistrust and I guess the disheartening of the community like we've seen in the past with certain industry partners, because again, there was no transparency, there was no accessible information for patients to understand what this process actually means and what could potentially happen if things should go wrong. I know a lot of the time people don't like to focus on the negative, but I think as a community that is so kind of mistreated, underfunded and under-researched, and then to suddenly have a lot of things happening within the space, it's important to explain these things so that we're aware of it. And meeting the community where they are. So as Buki mentioned a lot about patient groups, there are a lot of patient groups that she's a part of. I'm also a part of them as well as patient groups. You've got churches, schools, online platforms, but it's important that when you are doing these researches or whatever it is that you're developing, you engage with the communities. It's not just about going to the largest organization or the largest outlet to kind of share what's happening. Engagement should be sensitive, it should be inclusive, and it should ensure representation across age, gender, and also geography as well. And what I mean by that is you may engage an organization which is, one of the largest organizations in a country, let's say, but that organization doesn't actually represent the patient voice. And if you speak to other patient-led community groups, you might find a very different outcome in terms of what patients want, what patients need, and how they're represented by these organizations. So it's important to look at various different groups as opposed to just going to one and thinking that, okay, this is going to be the way that we're going to engage, we're going to do research, and we're going to get the results that we want. So As well as that, I want to talk about kind of endpoints when it comes to research and trial data, and considering outcomes that patients want in research. So a lot of the times, I think in trial data, there are different endpoints from different perspectives. So from a clinical perspective, from a research perspective, from an industry perspective, everybody, I think the ultimate thing is a cure. We want a cure, we want to fix sickle cell, and whatever that looks like, whatever that process is, that's what we're going to aim for. But as Bookie said, there may be patients that just want help managing whatever they're going through right now. So sometimes a curative therapy, the end result might be great, but does it fix fatigue? Does it fix chronic pain? What are the fertility options? What are the mobility options after the fact? How does a patient function day to day? Do any of these things change, even though the sickle cell as the disorder or the disease may not be there? What else has changed as a result of that? It's important to kind of encompass a holistic view. So not just the outcomes of what something else might be, but in terms of what patients actually want as well. So we want to basically highlight the need for outcomes that reflect how people live with sickle cell and not just the clinical markers. So traditional endpoints that might look at how many hospital admissions a patient has or the hemoglobin levels of a patient. Not all patients go to hospital to get management of their treatment. There are a lot of patients that manage their pain at home, and a lot of that is to do with the clinical mistrust that happens within the care setting, especially within the UK, definitely in the Caribbean as well. It's a global issue that when patients are treated in hospitals or go into an emergency setting, they are accused of being drug seekers, they're accused of being very demanding, they're accused of being angry, aggressive, all of these things. And a lot of these things are barriers to how patients deal with their crisis pain or with any issues that they're having. So measuring how many hospital admissions a patient has before or after a treatment may not be an accurate measure of the outcome of that trial if patients are not always going to hospital admissions. And what that also does is limit patients from accessing the trials, because a lot of them will say things like, you know, to be eligible for the trial, you have to have had this many hospital admissions in order to be able to access it. Again, if a patient is not someone that wants to go to the hospital and have to deal with the disrespect and the mistreatment, then they're not going to be going to the hospital. That doesn't necessarily mean that they are healthy at home and not managing with their sickle cell. So some of these markers need to be looked at and they need to be measured differently. Again, with the hemoglobin levels, just because a patient has a high hemoglobin level, it doesn't necessarily mean that they're not in pain and they're not experiencing crisis. We hear with a lot of patients that are on blood transfusions or exchanges. After they've had their exchange, their levels are high, but they're still in pain, they're still in chronic pain, they're still having crisis. And a lot of the time, because of science, clinicians will say, well, it's not possible for you to be in this pain because your hemoglobin levels are so high, but there can be a lot of other things that are causing this pain. It could be an infection, it could be various different things. So again, look, when you're looking at trial data, looking at like HB levels increasing, it doesn't necessarily mean that the outcome for that patient is going to be improved quality of life, no pain, and being able to do their day-to-day things that they would want to do. So the traditional endpoints don't always capture the patient priorities. And I think incorporating that would be an improvement into how patients not just access the trial, but also the trial data after the fact. Also looking at the long-term impact versus the short-term results, which I've touched on as well. Patients think about education, career, relationship, and their independence. Clinicians might just think you no longer have sickle cell scientifically, but even though that patient has received this curative treatment or this management of treatment, are they able to go to work? Are they now able to hold down a full-time job? Are they able to maintain a relationship, look after children? Are they now more independent than they were before? These are outcomes that should also be considered, because this is what for a lot of the community, these are what is important to us. So we need to be able to encourage researchers to measure success in different ways that can reflect the life outcomes and not just the clinical outcomes as well. So next slide. So just to kind of tie all of this together, the benefits for research and engaging the community, it would ultimately give researchers a stronger study design. So through early patient involvement and co-creation, it means that whatever is being developed, if the patient is involved from the inception, I'm sure that the design would be, I think, more appreciated by patients, more well received by patients. And ultimately, by having the patient involvement as well, it will increase the trust and the participation and the recruitment retention, especially when patients are then able to go away and engage the community in perhaps some research or needing more information. It's so powerful for a patient to be able to bring that to their community group to say, hey guys, I've actually supported this, or I've worked on this, and this is what we need in order to be able to bring this to market. So it's much more powerful to have that patient involvement, because it actually does go a long way in terms of engaging the communities and patient participation in any data that might be needed. Relevant patient-centered outcomes, so outcomes that go beyond the clinical markers and that actually reflect real life priorities for the patient as well. Better data quality by incorporating the patient-reported outcomes and their lived experiences. So as I mentioned, not just going by hospital admissions, but what other data can be used, or what other technology can be used to capture patient data to see what is actually happening when they are outside of the hospital. Maybe there's a lot of technology now. We have like watches that are being developed and various different forms of technology that can measure oxygen levels, heart rates, different things. These should also be able to use to incorporate the patient-reported outcomes. And I think there needs to be a level of trust when it comes to patient-reported outcomes as well. I think that far too long, the clinical data is trusted because it's managed by clinicians and it's the science. But I think patient-reported outcomes should also be trusted. It just goes back to what patients have to face in hospitals and then not being believed. So if a patient is saying for 5 days out of 7 of the week, I have felt like this, that should be valued just as much as someone's hemoglobin levels. So there needs to be ways that we're incorporating that into the patient-reported outcomes. And then a greater long-term impact. So as the research would then align with what improves quality of life, the benefit there is that we'll see, I'm sure that we'll see a lot of treatments that, won't be pulled from the market for certain reasons because they align with a lot of different things. It's not just an increase in clinical data, but there's also less side effects, less symptoms, and probably helps patients to see what they want. Next slide. Ooh, next slide. That's it. So key takeaways, I tried to put kind of mine and Bookie's points together. So engage, involving patients and communities from the inception of research, invest in patients, so support patient organizations and communities through funding, resources, and also capacity building. If you want to be able to involve patients from inception, be able to trust their patient-reported outcomes, and there has to be a level of capacity building and understanding that we give patients to enable them to be able to deliver on these things. So do we need more expert patients? Then let's teach them how to become expert patients. Let's teach them how to empower their communities as well, so that research and data is then going to be a lot stronger. Patients will understand more, they're able to report better outcomes. So it's important to be engaging these communities. It's not just a case of when something's coming to market, oh, let's see who we can get to bring it out, or we need to get more information on patient community, so let's send out a questionnaire and hope that everyone does it. No, if you invest in patients and patient-led organizations from the beginning, that will build trust. And it also builds familiarity with the patients as well. So your organization or the name then becomes something that's recognized, that's trusted, and in the long term, that will definitely help. And to collaborate, so develop healthcare and research models that value the patient voices as equal partners. So patients are just as important as clinicians, as researchers, as Buki has said, we are the experts. It's impossible to kind of, we're all on different playing fields, but they're even playing fields. So we have to actually value each other so that we can bring that together. And once we do that, hopefully everything should work in unison and be a great positive outcome. And we'll have lots of new treatments and lots of great research. Yeah.
Thanks, Jenica. I'll stop sharing now and see if we have any questions from the group.
I only have 12. I don't want to hog. This was awesome. What a great kickoff to this program. Thank you so much. I'll start with Jenica, but I think this is also for you, Bukola. Not sure you know, but you may, that WHO runs some regular processes for assessing therapeutic profiles for various diseases. And they are called CATO and PATO. CATO's for adults and PATO is for children. And they just ran a 3-day program that I was part of this week on sickle cell disease, where we brought in technical experts. It's a contained activity that does focus on clinical feedback. It doesn't include pharmaceutical feedback. It doesn't include patient feedback. But that's to get the landscape from a clinical perspective. And then it's open for review by the general public, where community activists can share their thoughts on what transpired during PATO. So I'll work with Ivy to make sure that you hear about the call for public comment on the therapeutics journey. It will address what we have on the market now. It'll address the status of all drugs that are in drug development. And it won't necessarily get at why things are failing, but it will tell you where they are and why they failed, perhaps. But it's a good start. So I'll make sure that you get that. And I'll wait on the next 11 and so because I don't want to hog.
Yeah, sure. Thank you. And yeah, I look forward to the information from Ivy.
Mhm.
I don't think anyone else has their hands up, so feel free to
Okay.
away.
I wanted, when you talked about, I think you did this, when you talked about personalizing care, and I thought the story Jenica's, one of you shared about, this powerful relationship you established with a doctor where they really showed you respect. They treated you as a peer, as a person. That's beautiful to hear. But we know that for all kinds of reasons, that doesn't exactly happen in a lot of resource limited settings. And probably there's at the core of it is a lack of understanding of sickle cell disease journey. There is some arrogance. It happens with doctors sometimes. It's hard to perform surgery on somebody and be the decider of wellness and life and death and not have arrogance rub off on you, unfortunately. But I want to address that in a different kind of way around how do we personalize care. You gave a lot of examples about that, but I'm curious about as we try to improve care in resource limited settings, we know we need to move from the hub to the spoke to get care closer to patients. And that's not trivial because you have to enable and make sure the hub can do what it's got to do and then start working your way down to district hospitals and primary healthcare centers. How important is it for a patient to have regular care that's local? How are they willing to go to district hospitals for certain type of care? Because as we think about the diagnosis journey and the treatment journey, knowing that demand from the patient really pushes us to help decentralize care. So your thoughts, please.
Yeah, sure. I'm happy to start. I think decentralizing is definitely important because I gave the example of the difference. So I can give two examples of Nigeria and the UK. So in the UK, for example, your general things, you go to your GP. But oftentimes the GP is really hesitant to do anything with you because they just feel like I don't want to touch it. It's sickle cell. I feel like I don't want to, I'm not an expert in this particular thing. So see your hematologist. But the way it works in the UK is that it takes 3 months to see your hematologist for anything, right? So your GP is who you can see the next day. It's the person you can go to down the road and make a complaint. But they often feel like because sickle cell is a hematology specialty, it's not something I'm sure about. There's definitely a hesitation there. And that 100% delays care. It delays you when you have a particular issue and you have to wait 3 months to see the specialist. Whatever it is you're having is going to fester and is going to create more challenges for you down the line, right? So we
Yeah.
don't have enough of knowledge of sickle cell in the kind of local setting. Then the second part in Nigeria, for example, most care is delivered by nurses. That's something I also didn't mention, right? The most of the time, the doctor comes in, he says, okay, these are the things we need to do, and then he goes away. You don't see him again until the next day. The person you interface the most with is the nurse, right? The nurse is the person that comes, that administers, that does all these types of things for you, and is usually the first person that is seen in the local communities in Nigeria. And so really the empowerment of nurses is so vital, so critical to care, because they are the people, usually if parents have children with sickle cell, oftentimes the first person they'll go to or they'll see is a nurse, right, before they see that doctor. And so the nurse themselves have to really be empowered when it comes to sickle cell and have that knowledge regarding all the kind of basics. Obviously, there's no replacement for a doctor, right? When there's something that's critical, they have to see a doctor. But that first line of defense, as you kind of say it, is the nurse or is that person, and the way that they handle whatever situation it is so critical to the patient journey. So many of the complaints that we see, Jen and I see with the sickle cell community in the UK is actually with nurses, very rarely with doctors, because you just don't see enough of them to even have time to complain. It's usually because the nurse is not listening to me, the nurse is not giving my pain medication, the nurse is not doing this and that and this and that. And so that front-facing part of the medicine, of the healthcare delivery is so vital. Jen, I don't know if you wanted to add anything as well.
Yeah, I think I just echo what you're saying in terms of the front line staff is not necessarily the doctors. It is kind of the nurses and who patients see in the community. So in terms of like having the hub and then trying to kind of, break that down, I feel like there's something that they do in Jamaica with the Ministry of Health, which is there's one main hospital, which is in the capital, which is in Kingston, the sickle cell unit, but the doctors and the hematologists and the specialist nurses at the sickle cell unit go around the island into different smaller parishes and then train the healthcare professionals in the different parishes so that patients don't necessarily have to travel to be seen at the main hospital.
Wow.
I feel like it works here because it's a smaller island, right? There's still the equal amount of patients that there are in Jamaica versus in the UK, but because it's a smaller island, it's much easier for the Ministry of Health to say this is what we're going to do and actually implement it. The issues that happen in the UK, and I'm sure this probably happens in the US as well, is that how do we make it compulsory for nurses to have to receive this training in order to learn more, educate themselves, understand sickle cell, and then deliver a better treatment? How do we make it compulsory for GPs, who are the first line of kind of like contact for patients, to feel empowered enough to give advice to patients, but also to know that, to have that understanding again, and that education around sickle cell and knowing what's good. I feel like there's a protocol of you have to go to school and you have to go to university and you have to be qualified and this, that, and the other. But I know patients that I believe have a lot more knowledge on sickle cell, what is an emergency situation, what can be managed at home, than perhaps a GP or someone else. It's food for thought, but in some countries where it may not be possible to employ a specialist nurse and employ a clinician, could we empower patients and have like a community member, a patient or a community member that's close to a certain area in the community that patients can go to for support? Can there be someone within each region that is educated to a level enough to be able to offer some advice as to when it's serious enough to need to go to the main hub, or to try these steps first before going further? I feel like it's about thinking outside of the box. We have something that has worked, and as the numbers of patients grow, as things change, as migration happens, and everything like that, we have to start thinking outside of the box in terms of care, because what's been happening traditionally is proving to be unsuccessful. So that's just
very powerful. Yeah, I know we have, I think as a member of this coalition is Chidi Yaya, and he collaborates with Stephanie Ibamir at Duke. Chidi's at University of South Florida or something like that, but they focus in Sierra Leone, and the focus there is exquisitely on nurse-led care for sickle cell disease. So it might be useful, Ivy, to see if Chidi, Stephanie, and I think there are also collaborators from St. Jude's that run a nurse-led boot camp for SCD, and they just had one in Nigeria. So it might be useful for us to think about them as the power of nurses, importance of nurses.
And I believe they're actually hosting their fall training right now. I think, is that this week or last week? So I do know that they are actively engaged, and that's wonderful within the power of our network. I know we're winding down in time, but thank you, Buki, and thank you, Jen, so much for this wonderful refresher and reminder, especially during Sickle Cell Awareness Month, that, community is so much value to the warrior, but we are stronger through ensuring that our communities are the greatest inclusion and representation across the different stakeholder groups. I think, something that always happens is that, we work in these silos, but it's so valuable to know that we are being supportive and not transactional with each other, that we are ensuring that we are highlighting those who we are serving. For those of us who are, of different stakeholders that are not the patient-led ones, but we're still giving this platform and the amplification and the due thought and the careful consideration that we are stronger because we work together, and we ensure that these processes get built in, and these better practices served. I have dropped in the chat an evaluation survey. We will be sending it via email to those who have attended today. And so we thank you so much for your time today. We hope to be able to offer more sessions. This was just our inaugural session to be able to test out the process. So we're looking for more organizations that are be able to build the capacity and the resilience of the organizations who serve, and be able to really ensure that we are growing stronger together and learning from each other, and really framing these lessons learned in all of our initiatives so we can ensure that better practices are served. So thank you, everyone.
Thank you, Ivy, and happy Sickle Cell Awareness Month to everybody.
Thanks, everyone.
Thank you.
Bye.
Thank you. Goodbye.